Welcome back. Today we'll spend a few minutes talking about colon polyps, and then the majority of our time will be on colon cancer. We will only talk about adenomatous polyps, since these are the pre-malignant lesions. Grossly, they may be pedunculated or sessile, and histologically, they may be classified as tubular, which is the most common variant, tubulovillous, or villous adenomas, which are least common. Villous adenomas are the ones that we worry about the most, since there's a 50% chance that a villous adenoma that is greater than 2 centimeters will contain a focus of invasive cancer. Here's a few images showing what these polyps look like via the colonoscope. A pedunculated polyp is relatively straightforward to remove via colonoscopy. However, a large sessile polyp presents technical challenges, and this type of polyp may need to be referred to a surgeon for surgical excision. This is an image of a large sessile villous adenoma. They're most commonly found in the rectum or the right side of the colon. They look like cauliflower to some people. Surgical excision of this type of polyp should usually be done via a formal oncologic resection, since there's a high likelihood of finding a focus of invasive cancer. The reason why we're spending time discussing adenomatous polyps is that every colon cancer had its origins from one of these. The great value of screening colonoscopy is that it will remove adenomatous polyps before they ever have a chance to become an invasive cancer. One question for us to think about is, under what conditions is colonoscopic polypectomy sufficient treatment for a malignant polyp? In other words, if on final pathologic examination, a focus of invasive cancer is found in a polyp, under what conditions do we have to offer surgery? No surgery will be required for a malignant polyp as long as all of the following conditions are met. First, the histology must be well or moderately differentiated. There can be no evidence of lymphovascular invasion. There can't be any cancer or dysplasia at the resection margin. If it's a T1 lesion, it can't invade a deeper than the lower third of the submucosa, and it can't be a T2 lesion or greater. Okay, let's move on to colon cancer now. Colon cancer is a significant clinical problem in the United States. It is the second most common cause of cancer death in men and the third most common cause in women. Overall, the lifetime risk is about 5% for developing this disease. Colon cancer has been decreasing in incidence for older people, perhaps because of the impact of screening colonoscopy. However, the incidence has been rising at about 2% a year for people under age 50. There are several hypotheses about this. One favors obesity as the reason. Adjusting for age, the incidence rate of colon cancer has been declining. It seems to have peaked around 1985 and has been slowly declining since then. There has also been a corresponding age-adjusted decrease in the mortality rate as well. Like all the cancers we've discussed so far, the etiology of colon cancer is based on a complex interrelationship between genetic susceptibility and environmental insults. Most colon cancer cases that we see are sporadic. They just happen with no clear reason why. The next most common situation is where one or two family members may well have the disease. So there's a familial risk, but it doesn't fit any genetic pattern. True hereditary colon cancer makes up less than 5% of all the cases. Some of the known modifiable risk factors include obesity, alcohol, smoking, and a diet rich in red meats and poor in vegetables and fiber. Let's now talk about two of the most common hereditary colon cancer syndromes. The first is familial adenomatous polyposis. As you can see here in this gross specimen, the colonic mucosa is literally carpeted with thousands of polyps. In 1987, the gene for FAP was isolated. This is the APC gene, which is also detected in sporadic colon cancers as well. There's genetic testing available for family members of at-risk kindreds. The average age for detecting polyps is 15 years. By age 40, 100% of these patients will develop colon cancer unless we intervene. Since the APC gene affects every somatic cell, it's not surprising that there are multiple other associated problems with FAP. Gastric polyps are very common and fortunately are benign. However, duodenal polyps are also common, but these are true adenomas, and these patients have a high risk of duodenal cancer over their lifetime. In fact, duodenal cancer is the second most common reason for death in this patient population. Colon cancer, of course, being the first. These patients also develop desmoid tumors. Some of the FAP variants are listed here: Gardner syndrome, Turco syndrome, and a variant called attenuated FAP, which has a later onset with less polyps, but still with a significant risk of colon cancer. Genetic testing for the APC gene is now available for at-risk patients. For patients who carry the gene, they should begin screening by flexible sigmoidoscopy beginning around age 10 to 12. These patients will also need to be screened for duodenal polyps and gastric polyps throughout their life. For a patient with familial polyposis, what operation will we do? A timely total proctocolectomy will eliminate the colon cancer risk in these patients. All of the colonic and rectal mucosa must be removed to the level of the dentate line. Most of these patients will have an iliopouch anal anastomosis as their reconstruction. It would be an unusual patient who isn't a candidate for this procedure. Perhaps someone who's morbidly obese would not be able to have this for technical reasons, and so they may need an ileostomy. An abdominal colectomy with an ileorectal anastomosis leaves the rectal mucosa behind. Since these patients will assuredly develop a rectal cancer, this procedure should not be done. Hereditary non-polyposis colon cancer is the second inherited colon cancer syndrome, and actually it's more common than FAP. This disease is often called Lynch syndrome as well. It's an autosomal dominant inheritance pattern, and as you can see from this little chart here, about 80% of affected patients can be expected to develop colon cancer. Women with this syndrome have about a 60% chance of endometrial cancer and a 15% chance of ovarian cancer. Patients affected with HNPCC inherit one of 4 mismatch repair genes. The job of these genes is genetic proofreading and correcting any mistakes that may occur, so it's easy to see how cancer might develop if this function has been lost. Genetic testing is available for the 4 known genes responsible for this syndrome. The pathologic hallmark of this disease is microsatellite instability. The key to making a diagnosis of HNPC is a careful family history. Originally, this disease was defined only for colon cancer, but it has been expanded to include some unusual cancers like small intestine and ureter, as well as endometrial cancer. The diagnosis requires that 2 or more generations be affected, and one is a first-degree relative of the other, and 1 or more affected patients should be diagnosed before the age of 50. The screening program for patients known to carry one of the HNPCC genes is directed towards the most common cancers. So these patients will need a colonoscopy, and women will need a careful gynecological examination. These screenings should begin by age 25, ideally, or no later than 5 years before the lowest age of onset in the family. So here's a case to consider. What do we want to do for a 40-year-old woman with a cecal cancer and known HNPCC? The first thing to consider in this patient is that a segmental colectomy should not be done. Although synchronous cancers aren't terribly common, synchronous polyps most assuredly are, and it wouldn't be unlikely that this patient develops a metachronous cancer later in life. So the question for us is going to be, how much of the colon should we remove? It might seem like a total proctocolectomy with an ileopouch anal anastomosis is the right choice. And this is certainly an option for any one of these patients. But interestingly, it is rarely the option chosen. Most patients with Lynch syndrome undergo a subtotal colectomy with an ileorectal anastomosis. Of course, this leaves the rectum in place, and that rectum is at risk for developing a cancer. My guess, and it's just a guess as to why this is a reasonable option for this patient, is because stage for stage, Lynch syndrome patients have a better outcome than the sporadic colon cancer patients. And since this patient isn't guaranteed to develop cancer in the remaining rectum, and if she does, presumably has a better outcome, it seems reasonable in most patients to just proceed with a subtotal colectomy. Prophylactic colectomy has never been recommended for this patient population. And for our patient, who's 40 years old, if she's done with her childbearing, it's certainly reasonable to discuss a TAH-BSO with her. And in my opinion, it's likely the right thing to do for her. Okay, onwards. We'll talk about the most common type of colon cancer now, the sporadic variant. This picture shows the distribution of colon cancers throughout the colon. As you can see, about 60% of cancers are located in the rectosigmoid area, and about 20% are located on the right side. Over time, there's been a slow shift towards the right side of the colon. The issue of colon cancer screening is a confusing one, and this slide certainly shows the confusion. There are multiple different options, and the one best way has never been identified. One thing that most doctors would agree on is that for high-risk patients, colonoscopy is the way to go. Colonoscopy for every average-risk patient, however, presents certain problems. The test is expensive, it's invasive, it requires unpleasant prep, it requires time off from work, and it has a complication rate associated with it. So this colonoscopy, as good as it is for identifying early stage cancer and polyps, does not enjoy a very high penetrance. There are multiple other options besides colonoscopy. Every one of them has their pros and cons, and the one best way clearly hasn't been determined yet. The American Cancer Society is now recommending that screening, however done, begin at age 45 now. The old recommendation was age 50. Colon cancer is staged via the TNM system, and you can peruse this chart at your leisure. When we talk about rectal cancer next week, preoperative T-staging becomes quite important, so we'll deal with that then. Clinical stages are on the far left. The one to remember probably is stage 3 is lymph node positive disease. Colon cancers have different gross morphologies and different symptomatology depending where on the colon they're located. Right-sided cancers tend to be exophytic, and their typical presentation is with an iron deficiency anemia. The patients will often complain of weakness, getting tired real easily, and may have a hemoglobin as low as 8 or 9. Left-sided colon cancers tend to present in a more constrictive fashion, and so the common symptoms are constipation or change in stool caliber or change in bowel habits, and some of these patients may have bright red blood per rectum as well. Rectal cancers tend to be more of an ulcerative nature. They can present with bright red blood per rectum as well. One symptom that is characteristic of rectal cancer is tenesmus. This is the feeling that you need to defecate, but when you sit on the toilet, nothing happens. Here's a couple of images from the web, which shows a sort of typical fungating cecal cancer and as well a typical apple core type sigmoid colon cancer. It's not hard at all to imagine that the cecal cancer causes bleeding, slow bleeding, and that the sigmoid cancer presents with a change in bowel habits. CT scans are part of the standard workup for any patient newly diagnosed with colon cancer. Typical findings of the tumor are primarily a thickened colon wall. CT scans are very good at showing us the relationship between the tumor and neighboring structures. The colon abuts many important structures as it makes its journey around the abdomen, and it's not at all uncommon to find that the tumor is adherent or even invading surrounding structures. Here we see evidence of the duodenum being invaded. This is something you'll have to be suspicious of in someone who has a hepatic flexure tumor. And over here we see a sigmoid cancer that has grown into the bladder. None of these patients are unresectable. They're T4 lesions, but if all the disease can be removed, they should be resected. CT scans are also invaluable for looking for metastatic disease. The presence of this disease may well influence whether we resect the colon mass or not. If the colon mass is asymptomatic and the patient has multiple liver metastases, chemotherapy is probably the better course of action. This patient has 2 large liver mets, and this patient over here has extensive periortic adenopathy. Patients should also have a chest CT. The presence of pulmonary metastasis may well influence whether we operate on the colon or not. Patients who have a solitary pulmonary metastasis or a solitary liver metastasis are not incurable and may well be candidates for surgery at the time of resection or after chemotherapy. CEA is the tumor marker most commonly associated with colon cancer. However, it's not specific at all for colon cancer, so this does not make it useful for screening or diagnosis. However, if a patient is diagnosed with colon cancer, then the preoperative CEA level is an independent predictor of outcome in patients with stage 1 to 3 disease. Lower CEA levels are associated with better results. Another occurrence is if the CEA doesn't come back to normal after resection. This usually means that there's an additional disease and more workup is required. This will commonly be a PET scan looking for micrometastasis. CEA is also used in the follow-up period. Patients should have this level checked for the first few years every 3 months or so, and a rising level is always worrisome for recurrent disease and needs to be followed up with imaging. All right, onwards to the surgical management of colon cancer. Let's mention a few general ideas. The first is that any non-emergent case should have a standard mechanical bowel prep. Bowel preps do come in and out of fashion. Currently they're in fashion, so it's best to do it. The operations we do for cure are really about the lymphadenectomy. We don't typically have to worry for abdominal colon cancers about proximal or distal margins. They will become major worries when we talk about rectal cancer. But for the abdominal colon cancers that we're talking about today, the operations we do is about removing the lymphatics. The lymphatics follow the arterial supply of the colon, and so our job is to divide the main blood vessels of that area of the colon as close to the origin to the SMA as we can. This allows us to retrieve the most nodes possible. It's been determined that at least 12 nodes should be removed. In fact, the more nodes removed, the better. I've got a chart in just a few minutes that shows survival is improved depending on how many lymph nodes you removed. And the last point is, if the tumor is adherent and not obviously invading adjacent organ, you shouldn't finger fracture that tumor away. You'll leave tumor cells behind. So if it's grossly invading, obviously you need to do a resection. Even if it's an adherent, you should do a resection. That doesn't mean you have to remove the whole organ, but you do need to remove the part of the organ that the colon mass is stuck to. This picture shows very nicely the location of the lymph nodes. Some of the lymph nodes are located along the colon wall, but you can see how the lymph nodes march along the major vessels. So when we do a cancer resection, for instance, a right colon resection, you can see we're going to want to hug the SMA and get all these lymph nodes. A palliative resection can stay up in this area since we're not concerned about lymph node retrieval. I believe I got this image off up to date as well, which is a really good resource for this topic. This graph plots total lymph nodes removed against overall survival. Looking at just the top line, this one over here, you can see if 6 lymph nodes are removed, the cancer-specific survival is about 60%. If you get up here to 12, it's up to about 62.6%. So it's a small increase, but it seems to be real and seems to be consistent throughout the different time plots as well. Why might this be so? Why would removing more lymph nodes be better? My hypothesis is that it has to do with upstaging. The more lymph nodes you remove, the more likelihood you have of finding a positive lymph node. Adjuvant therapy is quite useful in colon and rectal cancer. So the one clear indication for adjuvant chemotherapy is lymph node positive disease. The more lymph nodes you remove, the more likelihood you have of truly determining whether they have stage 3 disease. If they have stage 3 disease, they benefit from chemotherapy. Colon cancer surgery can be done in a variety of ways. It can be done open, it can be done laparoscopic, it can be done laparoscopic with a hand assist port, or it can be done robotically. I'm not here to tell you which way is better because I simply don't know. One thing I think I can say for sure, however, is that no matter what your platform is, you need to do the same oncologic operation. All reports comparing laparoscopic to open surgery indicate that the 5-year disease-free and 5-year overall survival are the same. So from an oncologic standpoint, you can do the same operation no matter what platform. Minimally invasive surgery offers several potential advantages, including decreased pain, perhaps better cosmesis, and shorter hospital stays. Whether this is true in all cases, or even most cases, is really unclear, since most of the reports in the literature will always be the best case scenarios. Economic issues need to be considered as well, and there will come a time when the cost of procedures become very important to hospital systems. Let's now discuss some of the more common operations we do for colon cancer. Here we see a patient with an ascending colon cancer, and the standard operation here is the traditional right hemicolectomy. That's going to remove the ileocolic, the right colic, and then we have the right branch of the middle colic. And the goal is to take these really as very close to the SMA as you can. For a lesion located at the hepatic flexure, the operation is slightly different. In this case, you're going to want to take the middle colic at its origin, so you'll get both the left and the right branches of the middle colic. For a cancer located in the mid-transverse colon, there are several possibilities for the surgeon. You can divide the middle colic at its origin with the SMA and just do a transverse colectomy. It's, however, often challenging to get the hepatic flexure and the splenic flexure together without any tension. So I think many surgeons do what's called an extended right hemicolectomy. You'll bring the ileum, which is well vascularized and can be done tension-free, up towards the splenic flexure here. For lesions located close to the splenic flexure, there's some choices to be made as well. We'll talk about a left colectomy in a second, that's certainly one choice. But again, the issue is getting the two ends together tension-free. Another alternative is an even more extended right hemicolectomy, where you divide the colon in the mid-descending colon and create an anastomosis to the descending colon with the ileum. Again, this has the advantage of bringing an organ with good blood supply and minimal tension to the anastomosis. Downside, of course, is that the functional result may not be as good. The patient may have frequent diarrhea. The other choice for a cancer located at the splenic flexure is a left hemicolectomy. This requires dividing the left colic at its origin, as well as the left branch of the middle colic artery. The challenge here is making a tension-free anastomosis between the two ends of the colon. If that can be done, this will give the best functional result. If it can't be done, my own personal preference would be to extend this into an extended right hemicolectomy, getting close to a subtotal colectomy. When doing a sigmoid colectomy, you need to preserve the left colic artery. That means you'll divide the sigmoidal arteries and the superior rectal artery near their origins. Most patients will require mobilization of the splenic flexure for a tension-free anastomosis. A subtotal or abdominal colectomy is a very valuable operation for the abdominal surgeon to have in his or her toolbox. It's going to require an anastomosis to the sigmoid or rectum. When would you ever consider doing this? Well, there's many indications. Patients with synchronous tumors, a patient who develops a metachronous cancer, or the Lynch syndrome patient that we talked about earlier. This operation also can play a very valuable role in the emergency setting with obstructing or perforated cancers. The downside of this operation is that the functional results may be poor, and some patients may even need the anastomosis taken down and converted to an endoleostomy. Let's talk about a few of the emergency indications in cancer surgery. The first will be the obstructing colon cancer. This will usually be located in the sigmoid or the rectosigmoid. One decision that will have to be made early on is whether this patient who's obstructed on the left side should have a stent. Stents are clearly indicated for palliation. So if our patient had multiple liver or lung metastases and a stent could be safely placed, that may well be the best approach for this patient. You could avoid a major operation. However, in the emergency setting for patients who are potentially curative, it's never been demonstrated that stenting works better than an immediate operation. Stenting has the potential value of allowing the obstruction to resolve and allowing you to bowel prep this patient. So it would seem to be an attractive option, but there's no evidence that I'm aware of that it actually is the better option for a potentially curative patient in the emergency setting. So in my opinion, an obstructing colon cancer that's potentially curative should have a formal cancer operation, if possible. There are many different options for a surgeon when dealing with an obstructing colon cancer. There are 3-stage procedures, there are 2-stage procedures, and there are even 1-stage procedure. We'll go through those now and see when we might consider doing each one of these. A 3-stage procedure first requires a defunctioning colostomy. This will usually be a transverse loop colostomy. Then later down the road, they'll present back for resection of the tumor and a primary anastomosis, and the last stage is closure of the colostomy. So this is 3 major operations. Each one of them have their own morbidity and mortality. So the morbidity and mortality of this entire procedure has to take into account all the morbidities and mortalities of these operations. So when would you ever do a 3-stage procedure? Well, it's almost never going to be your first choice, but there are some times when it will be the right operation. The first indication may well be a patient who has impending perforation of the cecum, and they're totally deconditioned, there are bad surgical risks, and they need something immediately done so they don't perforate. And so you do the loop colostomy, and then hopefully you get them in better shape for a more definitive procedure. The second indication, and perhaps the more common one, is when you go in there with the intent of doing a resection, but you find out that you can't mobilize this colon safely out of the retroperitoneum. If this tumor is fixed into the retroperitoneum or adherent to iliacs or ureters, it may well not be safe to proceed at all. And your sort of damage control out operation will be a loop colostomy. Sometimes living to fight another day is the better course of valor. Probably the most common approach to an obstructing colon cancer is a 2-stage procedure, or more commonly called the Hartmann's procedure. In this case, you will resect the tumor, give them an end colostomy, and then bring them back at a later date to close this colostomy. In selected cases, a 1-stage procedure could be considered. There are several choices. One is to do the resection and then do an on-table bowel prep with primary anastomosis. I personally don't like this for several reasons, but the main reason really is that the proximal colon tends to be very dilated, and making a safe and secure anastomosis between this dilated proximal colon and the collapsed or normal-sized distal colon has always struck me as technically a problem, and so I've always avoided this. In some cases, a total colectomy with an anastomosis, a primary anastomosis, can be just the right thing to do. Someone with an obstructing transverse colon cancer or splenic flexure cancer would certainly benefit from an extended right hemicolectomy. This is the oncologic operation you may well be doing anyway, and this is a relatively safe anastomosis as long as the patient is not unstable. You're resecting all the dilated colon so you can make a nice anastomosis between well-vascularized ileum to normal-sized colon. All right, let's talk about perforated colon cancers next. A colon cancer can perforate in one of 2 places. One is at the site of the tumor itself. The second would be at the cecum if the primary tumor is obstructing. If you have a perforated sigmoid colon cancer, the operation you would most likely do is a Hartmann's type procedure. You really want to resect this perforated colon. Just leaving a drain and a proximal ostomy leaves a source of contamination and is really not the way to go. That would only be a damage control procedure if resection was just not possible. If the patient perforates at the cecum and let's say has an obstructing splenic flexure cancer, then an extended right hemicolectomy would be a very good choice in this situation. If the patient were stable, you could do a primary anastomosis. If the patient is unstable, then an endoleostomy with mucus fistula would be indicated. Adjuvant therapy plays a very useful role in colon cancer. It's indicated for stage 3 tumors, that's lymph node positive disease, and reduces recurrence rates by 40% in this patient population. Other indications are less clear, but are often used. Patients with T4 tumors, obstruction or perforation, any lymphatic or vascular invasion, undifferentiated histology. Lymph nodes retrieved. If less than 12 nodes have been retrieved, this puts the oncologist in a bind because they feel like the patient may be understaged. So oftentimes they'll recommend chemotherapy in this group. Another reason for us to do an adequate primary operation. In colon cancer, there's no role for adjuvant radiation therapy, and there's really no role for neoadjuvant therapy as well. Okay, thanks for your attention. Next week we'll talk about rectal cancer.